Dr. Sangeetha Cancer Center. She specializes in triple-negative breast cancer. As usual, don't forget to like and share the conversation and share your questions in the comment section of this stream, and we'll get to as many as we can. So as we get started, can you just tell us what is triple-negative breast cancer and how does it differ from just your standard breast cancer?
Excellent question, and thank you all for having me here today. So triple-negative breast cancer is one of our three main subtypes of breast cancer, present in about 15% of cases. I would say it's characterized more by what it is not than what it is and what this triple negative is referring to. So usually when a patient is diagnosed with breast cancer, we look on their pathology for three specific proteins or three receptors because that helps guide how we're going to treat them. So two of these proteins are related to hormone receptors, and that I think we've heard of a lot in the public, that a lot of breast cancer are driven by our hormones that we have, and that's the most common type of breast cancer, hormone receptor positive breast cancer. And then that third protein is something called HER2, which is a growth factor that helps some breast cancers grow. When you don't have any of these proteins that are positive, that's what we call triple negative breast cancer. So it's sort of currently defined by the absence of something rather than what it is. Though I think in reality, it's a mixture of different types of tumors, and we're doing a lot of research now to better define, well, what is triple negative breast cancer by what it's actually expressing, not just what it's not expressing. So I think in the next few years, we'll start to see the definition of this change.
Okay, how long has this definition been around? Is it fairly new, or has it been newly discovered?
It's been there for quite some time. So I mean, I think traditionally we had hormone receptor positive or ER positive and ER negative disease, for decades. And then when HER2, that third protein, became to be known as relevant and that we can target this with specific therapies, that's when this ER positive and negative further branched into hormone receptor positive, HER2 positive, and triple negative.
All right, well, we have our first question in, and this is from Kristen. Thanks for your question, Kristen. She's asking, should people with a family history of triple negative breast cancer seek genetic testing and counseling?
So first I'll backtrack to the patient. So I'd say patients with triple negative breast cancer may qualify for genetic testing. And there's specific guidelines on if you're this age with this family history of this specific breast cancer subtype, you may or may not sort of qualify to be higher risk to warrant additional testing. So generally with triple negative breast cancer, if you're younger than the age of 60, everyone should be getting tested. Also, even if you're not fitting within the less than 60, but you might have family members with breast or ovarian cancer, if you're of Ashkenazi Jewish descent, or if you're metastatic with triple negative breast cancer, so that stage 4 has already spread, then everyone should be getting genetic testing at that point. Now, if a patient or if someone themselves does not have breast cancer, but they have a family member that has triple negative breast cancer, then I would say if the family member that had the triple negative breast cancer met those criteria, it's always best to have the person that had the cancer to be tested, and then based on those results, other people can be testing accordingly. But if for some reason that person wasn't alive or they're not available to be getting tested, then yes, I think that's a conversation that could be had about potentially testing someone who has a family history of breast cancer. And the other thing I wanted to point out is I think it's important to be tested with the appropriate counseling also. So I, for example, don't test my patients myself in my clinic, but I'll refer them to our genetic counselors and the specific genetics focused clinic, because you get a lot more resources than simply let's take your blood, get the test result, and comes back. But there are a lot of implications with this. Well, what do you do depending on what result do you get? So you'll get the appropriate support there, even up front of what would it mean for you? Do you want to get this testing or not?
Okay, well, that makes a lot of sense. We just got another question in. They want to know what your advice is to a newly diagnosed triple negative breast cancer patient. So maybe perhaps what does treatment look like?
So treatment. So one, I guess it depends on what stage you have, how far advanced is it. So let's say it's earlier stage, meaning it's in the breast, possibly in the lymph nodes around the breast, but hasn't spread further than that. Then, like other breast cancers, surgery of some sort, depending on how much of the breast needs to be taken out. That'll depend on how big the tumor is. Radiation may be involved. But even if we don't necessarily see cancer cells that have spread outside of this general area, It's possible there's microscopic disease that's too small to see, but generally once the tumor's above half a centimeter or so, we say you're at sufficient risk, then we should start thinking about giving treatments that affect your whole body and not just cutting out or radiating what's in the breast itself. Again, since triple negative breast cancer doesn't have one of those specific proteins that you can treat with a focused, pill or a medicine against a specific protein, chemotherapy is our main treatment option for a medicine that will go throughout the body to be, again, the focus is killing cancer cells that may have already spread to the bone or the liver or elsewhere that we may never be able to detect otherwise. And the goal of this is to prevent the cancer from coming back later and becoming stage 4 disease, where it's more of a threat to our life and how long, our natural lifespan would be. The other couple things I wanted to add to that is in metastatic, so stage 4 breast cancer that's triple negative, there are a couple other treatment options. One is PARP inhibitor. So if you have a hereditary mutation, a BRCA1 or 2 mutation, and you have triple negative breast cancer that's metastatic, that's another treatment option that's not a chemotherapy. It's a pill you can take once or twice a day. So that's been a fairly recent development that we've added, which is why it's important that metastatic triple negative breast cancer patients be tested for this genetic history, because that might give more treatment options for them also.
Okay.
And then most recently, in just the spring of this year, we had our first immunotherapy approved in metastatic triple negative breast cancer.
Can you tell me a little bit about what immunotherapy is and how it works in this disease?
So immunotherapy is a type of cancer therapy that basically allows your own immune system to fight the cancer. So by the time our cancers form, whether it's breast or otherwise, there's sort of been a back and forth battle between your cancer cells and your immune system, with, over the course of our lifetimes, our immune system getting rid of most of the cancers that would have formed. But when we have a clinically sort of relevant cancer, by then the tumor has figured out a way to sort of outsmart the immune system and be able to grow. But in some of these tumors, the immune cells are still in the actual cancer area. There's just something preventing the immune cells from killing the tumor cells. So immunotherapy, or the most common type that's now being studied, immune checkpoint blockade, it basically releases the brake on the immune system. So whatever was preventing those immune cells from killing the tumor, that's kind of released, so the immune cells can do what they need to do and start killing these tumor cells. What's been exciting about it, especially in some of the other tumor types like melanoma, where it would first shown to be most effective, is you had patients with stage 4 disease that were told they didn't have, too much longer to live, that had dramatic responses to this therapy that were not just short term, but people that are, living several years, to the point of some even almost having cures for what is incurable disease. So in breast cancer, there's a lot of interest, here at UT Southwestern, elsewhere, of seeing how we can apply this. And in February, March of this year, we approved immunotherapy called atezolizumab, which is one of those agents I described, in combination with chemo in newly diagnosed patients with metastatic triple negative breast cancer, if they test positive for a specific protein called PD-L1.
Well, that sounds like a really exciting development. So is this type of cancer, is it harder to detect than just a regular type of breast cancer, and how is it detected?
Yeah, so the patients we see in clinic, there's some that come because they had a symptom. They felt a mass, some abnormality, on the breast that led to them coming and getting a mammogram and ultrasound.
Okay.
And if you come in with a symptom, then we usually upgrade you beyond a screening mammogram to get a diagnostic mammogram or ultrasound to take a look. Others we catch from regular screening mammograms that are done, after a certain age or based on your risk factors. And if there's anything abnormal detected on those screening mammograms, then they again get upgraded to getting a diagnostic mammogram and ultrasound, and anything that looks abnormal is biopsy. And once we do the biopsy, our pathologists take a look and tell us, is this an invasive breast cancer? And then check for those receptors to see, is this a triple negative breast cancer or something else?
Is it more aggressive than other types of breast cancer, or is it pretty similar in terms of stages and whatnot?
So triple negative breast cancer tends to be more aggressive than hormone receptor positive breast cancer, for sure. So it tends to present a little bit larger at diagnosis, can affect younger women, compared to the other breast cancers, tends to affect more African American women compared to the other breast cancers.
What are the statistics? Like, how many people that get breast cancer fall into that triple negative category?
About 15% or so fall into that category.
Wow, that's pretty large.
Yeah, I mean, considering that, breast cancer in itself affects 1 in 8 women and is common, 15% of that, I would say, is very large. And it's still an area of need where we need better treatments than we currently have.
So you specialize specifically in triple negative breast cancer. Why is it so important for people to see a specialist versus maybe a general oncologist for this type of cancer?
Well, I think cancer treatments changed a lot over the years, compared to what it was 20, 30 years ago, where we had limited treatments. And so, one, there just wasn't a lot to keep up with. And it may have been, here's the one chemo regimen, and here's the 1 or 2 sort of anti-hormone therapies. But in general, there's just a rapid explosion of how quickly our cancer treatments are developing. So I think it's difficult to keep up with all the changes without seeing a disease-focused specialist. Not saying it's not possible, but it's a little easier to keep up when you're specializing in one particular area. And I see, triple negative breast cancers and other breast cancers as well, but at least focused on the breast cancer standpoint. And then the other thing is, oftentimes when you're seeing a specialist, or tertiary care centers or other centers where they have specialists, you tend to have access to more resources, such as clinical trials, that may or may not be there when there's a generalist, just depending on the practice.
Okay. So what are some of the common fears and some of the apprehension about treatments that you see with your patients, and what kind of advice do you give them?
That's a good question. So one, I think when I first see a patient, I think there's a lot of fear of the unknown.
Sure.
So oftentimes the highest anxiety time period is before starting on treatment, because you'll come to my office, that you have breast cancer, you may know the subtype and whatnot, and you're reading, what does this mean, what should we be doing, but you don't have a specific plan yet. And there's often a couple weeks, between then and when you're starting on treatment. You need to get specific lab tests, you may or may not need more scans, you may need a special, IV or Metaport put in to start treatment. So I think there's that uncertainty and the waiting period. And then I think when we transition into the getting closer to treatment, then I think we've gotten a lot better with chemotherapy, let's say, and side effects it causes that are not nearly as bad as they were before, and with some patients that are working while they're getting chemotherapy, and some that may not have that bad of side effects. Of course, we do have the whole spectrum of patients, but I think so some hair loss, it's something that nobody's expecting, to have to go through, at any age, and feeling nauseous, and it's several months of treatment, so not ideal if we can sort of avoid it. But I think in balancing sort of the benefits and risks, oftentimes it ends up being recommended. And I think, at least for me as a physician, I think that patient education is an important part of the patient and physician interaction, where they need to understand as much as I do of these are the treatment options, these are the pluses and minuses, so we can weigh together and see what is the best for each patient based on their individual values. And now as we have an aging population, it gets a little more tricky. You got to balance any treatment recommendation against their other medical problems to see what is and is not worth it, and how can we also maintain quality of life while recommending or going through any treatment.
Mm-hmm. Yeah, that makes a lot of sense. I mean, finding that balance seems really important. We do have another question, and this is coming from Kevin. Thanks for your question, Kevin. He's asking what research is being done to improve patient outcomes. I know you talked a little bit about immunotherapy. What else is kind of in the works or on the horizon?
Yeah, so I think there's a lot of different avenues of clinical trials that are being done. So immunotherapy, like I mentioned, I think that's one of the newer areas where there's actually a ton of clinical trials right now across cancer types, but definitely in triple negative breast cancer. Of the breast cancers, triple negative breast cancer seems to be the one that is most responsive to immunotherapy, but not quite to the extent we're seeing in some of the other tumors. So I think from a clinical trial standpoint, I think now we have new combination therapies and new drugs that are coming out from the pharmaceutical companies that may actually have some very exciting activity. So I think as a patient, it's good to consider these options and weigh that with your physician as to what may be best for you, because the potential promise of these is not just, we can kind of put off till whenever this cancer starts spreading, but hoping to, get people to live longer as a result. But even aside from immunotherapies, there's different targeted therapies. Like I said, now there's a lot of research of seeing, well, in triple negative breast cancer, instead of defining it by what it's not, what are the proteins that are there that we can get targeted therapies against? So
when you say targeted therapies, it's just very specific.
So chemotherapy works by killing any cell that's dividing quickly.
Okay.
Which is cancer cells, but that's why we get a lot of the side effects associated with it. Versus targeted therapy saying our breast cancer cells or these triple negative breast cancer cells are expressing this protein that is unique, or it's expressed much more there than it is in a regular normal body cell. So we're going to attack it with the drug that's specifically against that protein.
Okay, that's very interesting.
Yeah, and then now I think we're learning combining these targeted therapies and immunotherapies and possibly chemo, can allow us to get more bang for the buck, and hopefully then we can dial down on doses or sequence, figure it out so we can maximize the benefit and minimize any side effects related to it.
All right, well, we have another question from Tony. Thank you for your question. She's asking, are men also at risk for triple negative breast cancer?
Yes, so men are also at risk for triple negative breast cancer. Generally, men that are developing breast cancer tend to more often, even than women, have it associated with genetic abnormalities such as BRCA2 mutations. So when someone has a family history of breast cancers, that kind of adds up to being higher risk to needing genetic testing. We recommend getting that testing, and then men in that family, if there's a mutation found in a patient, should also be tested because they may be at risk for getting breast cancer as well as other types of cancer.
And you traditionally think of getting your breast exam as a woman, but what about men? How often should they be, kind of doing a self-examination, or is it common enough even for them to look for that?
Yeah, I'm not sure that there's actually great guidelines on specific frequencies of doing breast exams, as a man. So I would say in general, just being aware of any changes. But I think I would imagine, because that's not on the top of your list on things that might be abnormal, being a man and thinking you develop breast cancer, I think that's something we need more awareness in society, so that if there is an abnormality that's developed and you are able to see it, that is something that's considered to potentially get investigated by a physician. And at that point, we can image and see if something needs to be biopsied, and if that's what it ends up being.
Okay, so if a patient does find out that they have triple negative breast cancer, Kevin's asking what resources are available to them as they're trying to navigate their diagnosis.
Yeah, I would say the first thing is, whatever appropriate medical center is sort of nearby. And I'm a little biased, I guess, at a tertiary care center, but if there's a tertiary care center or another major oncology practice or cancer center, I would say making that appointment with the team, and the team often will be a surgical oncologist. I think it's always good to bring the medical oncologist early on, even if it's localized disease, because oftentimes we give treatments before surgery. So you may be getting several months of treatment even before you ever have surgery done. So I think it's good to sort of see a medical oncologist early on as well. And then a lot of centers such as our own have breast cancer specific websites. So our breast cancer, UT Southwestern website has information on what is breast cancer, how do you diagnose it, what are general sort of treatment options, and then we list our clinical trials, and we're currently renovating our site, but for example, we have our triple negative metastatic trials there now, and other centers oftentimes list their treatment options and who the providers are as well. But I think getting that appointment in so that this could be addressed sooner rather than later is helpful, because it's a lot to navigate, and being at home without knowing all the specifics, and it's not even, you may not know, but it's just, you need a pathologist, you might need that you just need more information than you may even physically have. So it's easier to get a physician on board to be your teammate to help navigate that.
Okay. And now we just have a few minutes left, but Alec just asked a question. I know we kind of touched on clinical trials and research, but he's asking what clinical trials are happening that you feel are significant to future treatment options. And I know we talked a little bit about immunotherapy, but maybe you can touch on it again.
Yeah, I mean, so there's some clinical trials that have recently reported out that have not become standard of care yet. So again, since my focus is more on immunotherapy, I'll say in the last month, the European Society of Medical Oncology meeting, they reported on a clinical trial including immunotherapy along with chemotherapy, not in the metastatic breast cancer setting, but even earlier on when it's just in the breast and the lymph nodes. And found that adding that immunotherapy during those several months of chemo and then continuing the immunotherapy after surgery for a few months significantly improved, increased the number of patients who had complete disappearance of tumor by the time of surgery. And, again, it's sort of the first report, so we don't have long-term follow-up yet, but even with the limited follow-up, when they followed for, a couple years out, less of those patients had the cancer come back and become a problem in stage 4 disease later on. So I think it'll be exciting to see how those results develop when we have more follow-up, and if FDA and others move towards potentially approving that treatment in the earlier stage setting for us to have as a treatment option to discuss with some of our patients.
So it might be more of a first-line treatment instead of
for when it comes back.
Okay,
right.
That makes sense. Wow, that's really encouraging. So hopefully.
Yes, fingers crossed, we'll continue seeing, that kind of data, and then with time also figure out, because again, we're getting better and better treatments, but I think there's also a move towards, there's some patients maybe we're over-treating, so can we cut back on treatments on? So I think clinical trials both lead to improved treatments, but also, now some of our results tell us there's patients we're not treating with chemo now that we used to treat with chemo because of trials we've done that have said, these patients are good enough with, without this, they don't need the side effects from something if you're not going to benefit from it also. And then, obviously there's a lot of trials where we don't have a clinical readout yet, here and elsewhere that are, again, looking at different combinations of targeted therapies and immunotherapies that may be appropriate for patients. And I think we're moving towards a lot of personalized medicine now. So a lot of, the trials we definitely have open look at sequencing of the tumor. So, from your tumor biopsy, we'll actually look in the tumor and see in your individual tumor, what is abnormal? If this protein is abnormal, hey, we have a trial that's specific against this protein and hoping that you're one of the patients that will respond to it. Similarly, if, these components are there, here's an immunotherapy that may be appropriate for you because of what we're seeing in your tumor instead of just broadly for everyone.
Okay. Well, that is all great information. We are about to wrap up. Is there anything that you wanted to add that I haven't asked you today?
Open-ended question. No, I think this has been a great discussion. Again, thank you to everyone that participated and is watching and asked questions, and thank you all for having me. If I can help in any way in the future, happy to do so. So thank you.
Thank you so much for joining us, and thanks to everyone who tuned in. If you have any last-minute questions, feel free to ask them here. If you enjoyed this chat and feel like it could be useful to your friends or family, please share it on Facebook. This will also be available on YouTube later today at UTSW Med. Thanks again for joining us, and we'll see you next time.